Thank you very much. I'm honored to be invited to address AMWA, and actually looking back over my notes, I addressed this gala in the year 2010. So it's nice to be back 8 years later, and I'm going to reflect on that in a few minutes. There's so many people here that I would love to acknowledge, but you heard that alert for 30 minutes, so I'm being held to time, and I don't want to use 15 of my 30 minutes calling names, but there are actually two people that I do want to acknowledge. One is Connie Newman, who's coming in as your new president tonight. Because we're both Wellesley graduates, and I have met her on the campus of Wellesley where she's organized Wellesley Women in Medicine. So that's all right if you're not a Wellesley alum, but it's always nice to acknowledge someone who has the same alma mater, and how touching to be here at the same time that she is being installed as your president. The second is someone that I'm sorry I was not here for the awards presentations, because you probably would have had to pull me down, because I certainly would have jumped up to give more compliments to, and that is Marshall Wolf. I don't know how many of you, what was said about him when he received the award, but as a very sort of, at first shy and then sort of aggressive, and in the terms of the 60s considered militant, probably nowhere considered militant today, intern and resident, Dr. Wolf was very generous with his time and gave us so much guidance as we worked to increase diversity of house staff at Harvard teaching hospitals and later at BU and Tufts. And this was in the late 60s. I haven't seen him in probably over 20 years, but the fact that he was being honored, we're going back almost 50 years. And so I'm just delighted, and please give him you don't have no idea how much this man has really done that I could attest to. And for the others of you who are my good friends, former scholars, those that I've met, those whose names I've forgotten, but faces I remember, I apologize, but I'm going to get on before she's told me that I only have 20 minutes left, and if I stayed up finishing this talk, I want to get through it. And I chose the title, The Changing Faces, not face, but the Faces of Medicine. I've been talking at a number of different places and attending match day ceremonies and looking at graduating classes, and it has struck me, there was that National Library of Medicine exhibit on the changing face of medicine, and then Crystal Emery has an exhibit on the changing face of medicine, and then I've seen many institutions who've come up with programs called the changing face of medicine. But for those of you, and there are a few in this room who've been around as long as I have, and you've heard me say going back over 50 years, so you can, yes, it's been over 50 years since I finished medical school. But thinking back over those years, I was thinking there really have been changes in the faces of those who are in medicine, how medicine is practiced, and what medicine includes in terms of our attitudes and research. And thinking about that, thinking I needed to be on a positive note, I chose opportunities and optimism. I probably chose that in the middle of the night too, but it sounded good, and I'm going to try to address that a little bit. Now I'm going to give you my 100-slide presentation. No, I'm just joking. Could I have this? So, I look back at my talk when I spoke to you in the year 2010, and actually I liked a couple of the sentences from how I started my talk back then. One was, because remember that was the 95th anniversary, I think. It was leading up to the centennial anniversary. And my thought at that time was there is much to celebrate, yet there are many challenges left to overcome. We've come a long way, but there's still more to do. And in medicine and in the full contextual understanding about women's health and health care. And then I had this as my second paragraph, which was reflecting back on Dr. Bertha Van Hoosen, and thinking about what has happened with women in medicine over that time, and that For many years, we continued to see women, and especially women of color, underrepresented in medicine and science. But over recent years, and at that time, back in 2010, we were beginning to see that change. And so we have been thinking about, and we still hear that excuse, and actually I noticed I had put in that poor old pipeline. That was really how I felt, because the pipeline keeps being blamed for women not being in leadership positions. But we've been around for a long time, and so there's no excuse about there being a lack of qualified women because of the pipeline. I'm glad to see I brought that out 9 years ago, 8 years ago. But even that report from the Institute of Medicine Beyond Bias and Barriers, and looking at all the literature today, and many of it published by many of you in the audience, we know that it's not the numbers or too few numbers of women. It is the institutions in which we function, the environment in which we work, which have not been constructed to be, at least until now when we're beginning to see changes, to accommodate being a woman in medicine. So on the occasion of this 103rd anniversary celebration meeting, change is still evolving, but the faces of medicine have changed forever. It'll never be back to, we don't think, what it used to be. But it is our challenge, and I include myself with all of you, to ensure that new opportunities, remember I use that term, opportunities and optimism, that there are opportunities that will be provided in the future with optimism for the young folks and the folks coming behind us, both male and female, for our profession. Now, I'm not giving you a thought after you've been sitting in lectures all day, all weekend. You don't need a serious talk, so I'm going to approach this a little differently and throw you some questions. Not going to give you answers. I just want you to think about these things. And I will talk about a few things. You know, if you invite me, I have to say something about women's health, so I can't get away from that. But I was thinking, and in this room, we have many generations represented. Now, those of you who came along with me, before me, or shortly after me, when I asked, do you remember what the status and concepts of women's health in the mid to late 20th century were? Now, for some of the young students, and especially those in medical school, I'm going back 20, 25 years, and for some of you, you were in nursery school, if not just a gleam in your mother's eye at that time. So you may not remember, but maybe it is important that you do stop and reflect on how far we've come. 25 years seems like a lifetime to you, and it is. To some of us, it's like yesterday, and it's recent history that fortunately we've seen change. When you think about the changes, just think about what have been some of the positive advances in opportunities. I mean, both in terms of our careers, in terms of our research, in terms of availability of career opportunities for women in medicine. But also, do we have it all done? I don't think so. So what are some of the remaining major changes? And if you think about those, I'm not the expert. I have some thoughts, and I know the literature, and I have my experiences, but many of you have thoughts too, some of which you may have published. But think about it. Give it thought always. Because what are some of the major challenges that remain, and how would you address them? If you think about it, when you think about some of the advances, have you considered the need to not just think about them and let them pass, but to think about them in terms of preserving them? In other words, making sure we don't move backwards. Now, I've been around a long time, and it's interesting to me as I go to different institutions to speak. Yeah, I'm supposed to be retired, and I'm supposed to be at home watching TV and eating chocolates, but I am still out traveling around. And it's amazing to hear people talk about things we did 20 years ago, 25 years ago, as though they've just discovered it. It's new. Sex and gender differences may be important. We need women in clinical trials. We need to figure out how to get more minorities in clinical trials. What do we need to do to get in research careers? And I think, my God, did I waste 25 years of my life? Because we're starting over. So for those of you who've been around for a while, help make sure those coming behind you appreciate what we've done. I hate to use that old cliche about not reinventing the wheel, but how are we ever going to move forward if we stop every year and keep changing the tires on the car? We'll never get the car on the track, and we'll never get to the finish line. So think about that. It's important to secure what we've done and to bring about further opportunities. Now, I was looking, because I'm talking about changing the faces, and I found this picture, which you've seen, from AMWA. We think this is from 1936, 1937. And on your website, so don't knock me. I thought this was a picture because it was on the website this week of this conference, but we can't figure out when it was taken. So if anybody knows what it is, tell me. But anyway, I'm glad it's blurred, so you could have to assume that this is a photo of you at this conference. But just look at the difference in the dress of those who were at AMWA in 1935, and look at the difference and the diversity of the women who are in this picture. You can't see because it's blurred, but that's what I got from your website, representing you today. So let's look at some of the changing faces. And thanks to Tufts, where I was on the faculty, and they sort of claim me as still claim me after all these years, but I happened to be meeting with someone from Tufts and said, I need some before and after photos, so don't blame Tufts for these, but I got them. But isn't that a typical photo of a medical school class? For those, now for the young women in here, you haven't seen this because it's been different since you've been in, those who have just been around for 25, 30 years. But that's how it used to be. And compare that with today. Look at the women in that picture. If you go back to the previous one, could you find that woman in the previous one? Probably not there. There's one woman there. And then look at these graduates. That's how it used to be. And then let me just, if you don't remember, let me just show you my graduation class picture. Doesn't it look like that one from Tufts? That was, see, to the younger ones, that may seem like ancient history. To me, it was just a few years ago. And if you can't spot me, there I am with my all-male classmates and all non-minority classmates. So that picture is taken in the front of the UVA Medical School building, and I was down there last week, so there is my class picture in front of that building in the spring of 1967, the graduating class. And I was down there because I'm invited to give there's a Penn College at the medical school, and I love it. I'm invited to come down and hand out the match envelopes to the students in Penn College. So I was there last Friday, or was it last Friday? It was last week, I can't keep up. And look at the difference, talk about changing faces, right, at UVA. From the previous one, where there's me and all of my male classmates. I love some of them, most of them, not all of them, but most of them. To looking at this group from this year and how there has been a shift in the women. And here's a close-up picture. You know, that's just a random picture the photographer took because they sent me photos from Match Day. And so many of them showed these collections of women. And I thought back, even when we just had our class reunion, it was me and a few of the wives and my classmates. It looked different. So I thought, let me look at the AAMC flyer, just thinking about changing faces. So the most recent AAMC newsletter had pictures from various schools from Match Day. So this is recent news. This is from last, Friday. And that's at BU. And what's interesting is, see, for many of you, this may be old stuff, but I remember when there were no women deans of medical schools. And there's your woman dean of BU. And look at that mixed class. And this is Baylor. And look at the photo. I mean, you all don't know, I have no connections. These were just great photos that AAMC published, but they made my point. How different from my class picture of that old picture from Tufts. Look at that group on Match Day, women and men mixed picture. And this one, I think, was from University of Florida, South Florida. Go back to my graduation picture. I was the only thing lending any melanin pigment in that photo. To this one of a group, and we see diversity represented. And then I really was caught by this and so delighted because this was in the AAMC newsletter, and this is a guy with his husband there. A few years ago, you would not have seen this. So we have come a long way in terms of changing the faces in medicine. Now, I think back to when I was in medical school, and I thought I was really good because I had worked with a transplant surgeon. I was excellent on dogs. But I know there are a number of people in here who are surgeons and professors of surgery. But when I finished medical school, there were only about 3 or 4 academic centers that were even accepting applications for women for surgery. And if you look at the specialties, this is the most recent data in chart form from the AAMC. But when I think about it, some of us in this room remember when women were told, and if you did apply, not to bother to apply, and if you did apply, you might just sit in the waiting room and never be called in for an interview, which happened to many women I knew back in those days in the 60s. Fortunately, Dr. Wolf interviewed everybody, so I give him credit for that. And so we have seen a change in the face or faces of medicine. And when we look at the progression, this again is a AAMC chart showing what we talk about, which is we still need to address women in leadership positions. And we see we have increased so many, almost 50% for admission to medical school. And I think this year for the first time, it's over 50%, and how we still don't have as many leaders, we don't have as many deans, we don't have as many CEOs. But I can remember, as I'm sure some of you in here, I remember when there were no women deans of any medical schools in this country. And then there was one. And then the board got upset, and then there were none. And then eventually, I don't know how many of you remember, I won't call her name, but I remember I knew her. And then we went up to 1, 2, 3, then back to 2, and then eventually, so 16 is not great. We should be far beyond that. So on the one hand, we've got progress, but on the other hand, we still have challenges. And medicine and surgery, remember when there were no women chairs in the United States of academic departments of medicine and surgery? So how that has changed. So for the young ones in here, I'm not saying accept where we are, but appreciate the progress we made. But we all need to make sure that we continue to make progress, remembering where we were and moving forward. Now, we used to talk about all the barriers to women in their careers, or barriers to minorities in their careers. But the literature has shifted over time, and almost all of that gender bias and other things have now been sort of categorized under implicit bias and all the other terms we hear about it. So sometimes, and maybe somehow, I think that tends to make people feel better about discussing gender bias or racial bias if they don't hear it as gender bias or racial bias. After all, it's actually just implicit bias that everybody has, so maybe they're more willing to talk about it. Whatever, it's good that it's being discussed. But these biases, I think, do affect opportunities and our degree of optimism. And I've sort of summarized all of my talks and all my things about barriers to women, and this has become my new theme, that we need to face and overcome what I think are based on historical and traditional stereotypes and attitudes that we grow up with or are exposed to. And sometimes they are overt and subtle, and sometimes they are unconscious, and sometimes I know they're conscious and intentional. And this is a challenge to promote opportunities and to preserve optimism for our profession. So my thought is, let's confront the stereotypes in what we do, and let's overcome these biases, whatever you want to call them, but it's important that we do that, recognizing that these stereotypes exist, we are influenced by them, and making a difference. But thinking of that, when you witness what you think may be, whatever you want to call it, implicit bias, unconscious bias, racial bias, gender bias, outright homophobia, do you speak up about it? Or do you watch and go home and tell your family, I saw an awful thing today? But do you speak up and do you do something about it? Have you really addressed examples of implicit bias? If it affects you, or when would you? Have you spoken up for those who are your colleagues, or your mentees, or your mentors? Have you spoken up in support of them to try to overcome how these stereotypical attitudes may be affecting opportunities for yourself or for others. And to sort of summarize where I think we are, going from tradition to equity of opportunity, it comes down really for what's represented at the top. Didn't put that on this slide, but you know, the word comes down from the top, whoever's at the top. And if you're at the top, it's your responsibility to make sure that those under you get the message that it is important. And it should be reflecting gender equity and diversity are related to institutional. You can't just blame it on the institution, in your own personal transparency, fairness, and accountability. How am I doing on time? I'm halfway through. Am I over my 30 minutes? I'll talk faster if my southern accent will allow me to do it. Let me see what I can do. So when we think about changing the faces of medicine, and we give attention to barriers and challenges for women in healthcare and in scientific professions and quest for leadership and decision-making, we have to realize we always hear about the dual role of women. You know, dual role because we have families and personal responsibilities as well as professional responsibilities. But also, we have dual roles in terms of medicine. Because not only do we provide care, do we provide data, do we provide research, but we are also the beneficiaries, just like our patients, of the results of that research. And we may all be super women or supermen, but every now and then we need a doctor too. So we are the beneficiaries. And I remember when we started all this back when I first went to NIH and we started the Office of Research in Women's Health, you know, we'd have to talk about, you know, this Office of Research in Women's Health, and I have to start every talk and every lecture with, what is women's health? And, you know, almost always I'd get examples of, you know, response would be breast cancer, fibroids, cervical cancer. And don't laugh, because I raise that question even today. And even fortunately, you know, like what is the leading cause of death for women? It has changed over the years, but just think back to how you would answer that question, how you might have answered it 10 years ago, 20 years ago, and how do you answer it now? So remember when women's health was thought of as primarily that of the reproductive system? You know, at menopause, you figured you sit in a rocking chair on the front porch and that was it, because you didn't hear much about the health of women in the postmenopausal years, but that has changed. And I don't know how many of you remember this book when the Women's Health Initiative was going on. A lot brought it up, but I still have this book written by Robert Wilson, and I pointed out because it was published by a gynecologist. I'm told he was a lovely man, and I once was presenting this, and evidently his son or some relative was in the audience, but that's all right. It was in writing, and there it was. I quoted the book. This was during the time I was in medical school, and in this book, I just pulled out, I mean, there are some choice quotes in here, but it said, a woman's body is the key to her fate. Her physical, this is written by a gynecologist on Feminine Forever. Our social and psychological fulfillment all depend on one crucial test. Is it having a good heart, good mental health? No. Our ability to attract a suitable male and to hold his interest over many years. So I guess my ex-husband would say I really fluked out on that. So. But not only that, on the cover of the book, he points out, and it's all through this book, about his breakthrough. Oh, it's a great discovery. Menopause is a hormone deficiency disease, and it's totally preventable. How do you prevent menopause unless you die before you get there? I don't know. But this is sort of the status of where women's health was at the time I was in medical school. One really funny, and just one more quote, and we'll go on to something more important. I'm still talking about the 20th century, hoping when you think now of that question, what is women's health in the 21st century, you've gotten beyond this. But he said at age 50, which you know, there are no ova, no estrogen, a galloping catastrophe. Folks, forgive me, I'm really a galloping catastrophe. Estrogen can save women. Our breasts and our genitals won't shrivel. Women will be much more pleasant to live with, and we will not become dull and unattractive. Well, I may have become unattractive, but I sure as hell am not dull. But let me move on, sir. So do you recall Do you recall when women were not included in, when they were not included and often were consistently excluded from clinical research studies, and especially on those that affect both women and men? Women weren't included. And I like the term that I think Marianne Legato probably gave rise to, a lot of people quote it, but so-called bikini medicine for women, when the male was used in studies like heart disease and other conditions, and then the results applied to women. And that was sort of where we were in the beginning of the 1990s, when there was a call to start studying women in clinical research. And we heard the term sex and gender thrown around, and they were used interchangeably. And, you know, I recall when we started, you know, sex is an appropriate biological term. But, you know, you're in the government, and every now and then it is true. There are words that do get scanned out, and I remember I thought we should use the term sex when it was appropriate, and I found out some of my messages weren't going through, so I used every chance I could to talk about sex differences and the importance of sex as a biological variable, and eventually they stopped screening out those messages, and we got them through. But do you remember when published scientific journals didn't require or even think about asking, when you had studies published, and it might say there were women and men, but not say how many women, or think about doing gender analysis. Now, a lot of that has changed, and many of you in this room and others have really worked towards getting scientific journals to change those policies and emphasize. What good does it do if you've got an NIH policy requiring the inclusion of women in clinical studies and you can't publish it, the data is not published? And this is one time when, you know, the journal of negative results may be important, because if you don't find differences and you look, then it may be important to see that too. We still have a way to go on that, hasn't going. But around that time, when there was a lot of advocacy concern about women being included in clinical studies, and there was a lot of press attention to that, and actually, I think the Congress and the advocacy community and scientific community were very smart, because they really went to research to look at the importance of research, and we know why research is important, because it serves the basis for our medical education, our scientific literature, and for standards of healthcare and public health. So that was when the Office of Research on Women's Health was established, primarily to ensure the inclusion of women in clinical research, although it's gone on to set a research agenda and do other things. So with that came, I think, a lot of influence in changing our perception of women's health. And one of the major things I had to do when I went in to start that office, which hopefully we don't have to do today, but there were some who kept writing to NIH complaining that what a waste of money it was to put money in women's health because it wasn't needed. They didn't think, and that this was just being politically correct. So I must say we probably spent 5 to 7 years or more just trying to show that everything we did was based in science, was a science-driven initiative, and to show that what we were about or trying to do in an Office of Research on Women's Health with the inclusion of women in clinical studies was to demonstrate gaps or to fill in gaps in knowledge. So keep that in mind as you justify and think about why we still need to address some of those issues. And there's no doubt we can't take the responsibility, and I sure don't take the responsibility, but there's no question that having money made available to researchers to study issues related to women's health, I can think of some very senior scientists who've made some great contributions who initially said, I'm not a women's health researcher, but when there were funds available, they instantly became women's health researchers and have gone on to produce some fantastic research. So that shows that funding and science-driven initiatives can make a difference. I'm going to skip that slide because that's sort of my summary slide, but we've sort of changed the context of women's health from lifespan, from just reproductive years and the reproductive system to lifespan. And remember, women's health came up with this term of lifespan. Actually, Ruth Kirstein is the one, I can't claim I came up with, Ruth Kirstein came up with this concept of lifespan, that we need to think of women's health from the girl, from infancy, past menopause, into the elderly and frail elderly years, lifespan issues. including not forgetting the reproductive system, because there's still a lot of common reproductive issues we don't have the answers for, and there's not enough research. So include the reproductive system, but include other areas. And what we've seen happen is this evolution of women's health into what we used to call women's health. I think we still have it there, but it's really evolved into the science of sex and gender. And if you look at the program for this meeting, I don't have to repeat that. Just look, I started to count all the sessions and lectures on sex and gender studies at this meeting. It's exciting to me to see that, but we have gotten there. But if you think about it, and just think, when you were in nursery school, you were in kindergarten, you knew there was a difference between little girls and little boys, didn't you? And yet, it took until 1990 for science to say, maybe there is a difference between males and females, and maybe we should look at that in research. So what was a common basic fact wasn't recognized by the scientific community until we started dealing with inclusion in clinical studies. And another variable is that just as women are not the same as men in most instances, not all women are the same and not all men are the same. And to me, that's the basis of health disparities, if you think about it. And that's why research is important to me, to discover the reasons why different segments of different populations are different. And so that's why we need to recognize that not all women or men are the same. And so the NIH then changed its policy, which then got coded in federal law in 1993, to ensure that women and minorities are included in clinical studies. I was so proud because, that's what I was brought on to do, and I'd give these talks, and we'd testify before Congress about how many women were in clinical studies, and we were making progress. And then I started getting these letters from men on Capitol Hill, and then making public statements that the NIH was discriminating against men because all they were hearing about was the inclusion of women. So I learned how to deal with that. I just put it up the slide, right? It's assumed that men are already included, and what we're trying to address is the addition of women and minorities. Now, remember I pointed out that we started talking about this lifespan concept back in 1990-91 when Ruth Kirsch's team put that in place, and that has been our motto in women's health, and I hope for you as you address it. Just, was it last month, 2 months ago, the NIH has announced a new policy, inclusion across the lifespan policy, to make sure that research addresses children, because pediatricians, the pediatric population was concerned, and also the elderly, for those of you who are gerontologists or who are reaching the ages of interest to gerontology like me, to make sure that we are included. And I remember once being in Florence for an international menopause conference, and some guy from Romania, I won't call, in fact, I've forgotten his name, was complaining about the age of people in the Women's Health Initiative, and he got up and was saying those were just old women in those studies. And I got all wrapped up in the heat of the moment and forgot, I don't tell my age. And I was on the stage before this international office and said, today is my birthday and I just turned 63. Are you saying my health isn't important? And then I went, oh my God, I just told the world how old I was. But it does make a difference when you get to that age that you realize. So there is that new policy. All right, so I'm almost through now. But how did we get to the thought of really distinguishing sex and gender? This comes back to AMWA. Remember, we started this policy of inclusion in 1990. It was encoded in law in 1993. But there was this National Academy on Women's Health and Medical Education, NAMI, that used to meet here in Philadelphia. People from Penn, from Drexel, and then all of us up and down the East Coast. There were many who would come to Philadelphia for these meetings. And Linda Donahue, Jean Hamilton, and Sandra Levinson were some of us, and why am I blanking on her name? Oh, the president of AMWA for years from New York. Oh, I can't believe I'm blanking on her name. Who wrote some of the first textbooks on women's health from New York. You know what I'm talking about. Lila Wallace, that's right, would chair these meetings. And I remember Jean Hamilton would get so upset because people were still using sex and gender interchangeably. And she had this slide. And I asked her if I could have a copy, and they said yes, as long as I acknowledge where it came from. So I've had this slide since 1993 or 94. But to me, it made the point, if you're trying to point out what's the difference between sex and gender, she would say, do you really want to talk about gender examples of mice? And that kind of made the point. And from then, we really began, not just our office, not just me, but in general, the scientific community began paying attention to what does the term sex mean, what does the term gender mean, until eventually that Institute of Medicine report came out, Does Sex Matter? And that was in 2001. And then talked about and gave good reasoning for why basic science studies are important. So from that study, I thought it was extremely important because it helped to give credibility to the need. Some were fighting the thought about going to sex and gender studies and looking at basic studies, and that study helped us to give support to that. They titled that book, sort of that report that committee did sort of facetiously, Does Sex Matter?, thinking that would get people's attention, and it did. But on the other hand, we have an answer for that. Yes, sex does matter. It matters in science, it matters in healthcare, and we've made great progress. So, and finally, about this, and now I'll get to my last slides if you don't pull me off the stage here, is that this has happened. I mean, there have been years when people have wanted us to require female animal models, and in fact, even when I was at NIH, we offered funding for people to help develop female animal models when people said they couldn't do it because they didn't exist. But Janine Clayton and Dr. Francis Collins actually published in Lancet and have now implemented this policy requiring looking at sex differences in basic studies. And that's important. And when we talk about this, it's been interesting talking about this. I didn't implement it, so I just point out it's there, but it's a step forward. I've been amazed at how many senior scientists who've been working with cell lines for years have said to me, and I mean more than one or two, you know, I never thought about whether or not my cells came from a female or a male. So just think about that, but I won't say more. And so we have seen lots of progress, and I don't have time. I know that many of the presentations have covered many of these areas, but I think over the past 25, almost 30 years, we've seen a lot of research, and a lot of accomplishments in women's health, but we made lots of advances, but there's so much more to learn. So as I started on the occasion of this meeting, we know that change is still evolving, and the faces of medicine have changed, and it is our responsibility and challenge to ensure that new opportunities do continue to be provided, and not just new opportunities, but those who are coming behind us have a sense of optimism for the future and for the future good of our profession. We've made progress, but we've got to provide those further opportunities. We've contributed to the expansion of science with new knowledge, but we have to continue to impress upon others the importance of seeking answers to, remember, the scientific basis, not to be politically correct, but those gaps in knowledge about women and men. And remember, I point out that men's health has benefited from women's health because you can't compare gender differences or sex differences if you're not studying both men and women. So men's health has really benefited because you've got to study both. And we have learned that we must not just be aware, but we have to be participants in the best way I can word it is the socio-political environment in which we work and which we live, which is why I was delighted to see that you honored the students, because that is also a health issue and shows that you are aware of the socio-political environment in which they will work and where they live. We have to be participants, not just observers in our communities, and I don't mean just local communities or neighborhoods, but in the global community. And we have to use what we've learned and what we might not have learned but have witnessed others discuss, and our unique skills to provide new opportunities and tangible reasons for future optimism. Obviously, you see, I'm stuck on those words, opportunities and optimism, but they mean so much to me about being a physician, a doctor, a scientist, in what we know is an imperfect world. And one last bit of comment, advice, that as I reflect back on my career, I think really impressed me, and I want others to think about it. When you're considering your career, even if you're just starting, and if you're senior, thinking back over your career, what have been the incidents or who have been the individuals who've made the biggest difference? Sometimes they're positive mentors, and sometimes they're people who've been downright nasty to you that you decide you're either going to be like them or you decide you'll never be like them. When I was in medical school, you already saw what my class was like. Very few women. There was only one woman professor. She was a professor of pediatrics. And I thought how wonderful there is a senior woman faculty member. That woman was so nasty to me and the nurses, it was awful. And when we just had our class 50th reunion, the guys were all listing her as some of the favorite professors. And I said, you realize how nasty she was to the women, to your wives, the nurses you married, and to me, how awful she was, but she was great. And I really think, looking back, that it was that lack of having a woman in a senior position that I could talk to that made me think it was important for me to be there when students wanted to talk to me. So think about how your career may be affected by positive and negative experiences that you have had. It really can make a difference. And so while we know that many of you truly are superwomen, that you can do most anything, that you are super docs, for many of us, we know we're really not superwomen. Being a doctor may be enough for some of us. Remember, just as you do when you talk to your patients or you give community talks and you tell everybody else, you know, women are caregivers, but you got to take care of the caregiver. But stop and think, we as women, and yes, don't give me that look, because I know she's telling me I'm not doing that myself, but I can give you the advice that we need to take care of ourselves while, as physicians, as scientists, while we're telling everybody else. And if you want to say you're the super doc, you're the superwoman, that's fine, but some of us have learned to admit we really aren't. So I want to applaud you for your theme for this meeting, Women Igniting Change. I thought about that, and I really wanted to show a flame, and I thought, no, that might be bad, so I didn't show a flame igniting. But I like the idea of igniting change. And so I want to end this talk by saying, let's make that ignition an ever-continuing starburst of opportunity with optimism. I hope I didn't go too far over my 30 minutes. Thank you very much.